Good afternoon to everybody. It's a great pleasure to welcome back to the webinar of International Society of Autoinflammatory Disease. As president, I have to welcome everybody. As you know, this is a way to be linked during these very hard times. I think that we still need to meet and to discuss, to learn new things, and of course to share as much as possible as a society. Today we have a great pleasure to have an outstanding speaker that is our past president, César Ozen, is a past president, was a president of the society. She is a professor of pediatrics in Ankara, and together with Ojce Bazaran, today they will talk us about the new things and new development for familiar Mediterranean fever. It's a very interesting, of course, topic. We decided to make it very, very friendly, live, absolutely. So that could be some technical problem, no problem. We love the technical problems. We hope to solve, of course. And also, we invite you after the presentation of Professor Rosen to make a question, to give your questions, and maybe to write in the chat. But there will be also the possibility to make a direct comment. So I will call the person that make the question, and she will be able to enter and to maybe have a direct dialogue with the speaker. So to make it more interactive. Okay, so I finished. I give the podium, if we can say, the camera to Professor César Ozen. It's a great pleasure. César, thank you very much. It's a great honor. And please.
Good afternoon, good evening. Thank you very much, Marco, for the introduction. It's been a pleasure to work with Marco in all these years in autoinflammatory area. I hope all of you are well in these challenging times, but life goes on, so does our academic interest. And today I'll be mainly talking about familial Mediterranean fever, which you all know is my favorite subject, one of my favorite subjects at least. And what I'll do—
Sorry, César, can you share the presentation? That is better.
I thought I was sharing the—
No, the presentation, the PowerPoint as a presentation.
You can't see it?
Yes, I can see, but if you enlarge.
Oh yeah, I'm sorry. Oh, so sorry.
Okay,
well,
thank you.
As you said, there are technical problems.
It's fantastic. We love it. Don't worry.
Okay, so I'll start with the disease presentation, prevalence, talk about the diagnosis, what's new there, very briefly the pathogenesis, some difficulties we have in FMF, and finish up with management and treatment. So I think the chapter of autoinflammation started with the definition of the gene for FMF and its protein, pyrin. It's been a long road since 1997, and we're understanding that we're still lack a lot of information, and we still don't know a lot of things about FMF, although the gene was described in 1997. And at that time, we thought everything was solved, but it was not. Mind you, I was very, very young then, so don't calculate my age. So you can classify the autoinflammatory diseases in a number of ways. One way we classify them is whether they have excess IL-1 production, whether they are inflammosomopathies. So familial Mediterranean fever, FMF, is one of these IL-1 dominant autoinflammatory diseases or inflammosomopathies. It's the most common autoinflammatory syndrome over the world. And it's inherited in an autosomal recessive fashion. The MEF gene codes for the protein pyrin. It's clinically a prototype of an autoinflammatory disease, and it's the nature's experiment on inflammation, if you want. And it's characterized by these recurrent attacks of clinical inflammation in the form of fever and psoriasis, and laboratory inflammation in the form of high CRP and other acute phase reactants. And you all know that it's caused by the mutations in this gene, and mutated pyrin causes an increase in IL-1 secretion. Now, the most important discovery on pyrin in the last decade probably came from a Chinese colleague, Fang Xiao, who probably did not see a single patient with FMF in his life. What he showed to us was how different microorganisms were inactivating ROA, and how pyrin, as a pathogen recognition receptor, senses these inhibitor RAW medications. As you all know, in these autoinflammatory diseases, the main problem is in these pathogen recognition receptors, which are the main players of the innate immune system. So what Fang Xiao showed was that this was a primitive system, how pyrin sensed the microbes, and then pyrin itself promotes ASCO oligomerization and forms a caspase-1 activating complex, resulting in a lot of IL-1 beta production. Now, this Fang Xiao initially showed this with Clostridium, but we were always thinking about what the advantage of these carriers were, because I will show you in a second that it's very common in the Eastern Mediterranean. And this discovery actually led us to the way to identify what the advantage was for carriers in the Eastern Mediterranean, because there had to be an advantage for 1 in 5 individuals to carry a variant in the MEF gene. There should have been something that selected them. And it looks like it was plaque, because Yersinia uses the same route for activation of pyrin. And if you have a mutation in pyrin, you are able to mount a more steep response, a better IL-1 response, and a better innate immune system response if you're a carrier for a MEF mutation. So if you're a carrier, you had the advantage against plague. You didn't die, and since you were a carrier, you didn't get amyloidosis. And so this was selected in the Eastern Mediterranean in such a high rate. In this nice study that was mainly done by J.J. Chan, it was shown that the severe variants of MEF was able to mount a much better response of IL-1, whereas E148Q was not so good as a carrier in mounting a better response to Yersinia. Understanding this pathway also showed us the main route of effect of colchicine, because we had some hypotheses about how colchicine was effective in this disease, but it looks like one of the main mechanisms, along with the actin pathway, is this RAW activation pathway. And this is how colchicine exerts its effect in FMF patients and changes their lives. So FMF is indeed very common among the people of Eastern Mediterranean origin, especially Jews, Armenians, Turks, and Levantine Arabs. It was very common in Lebanese, in the North African Arabs that left Spain in 1492. So it's confined, it's very common in these ethnic groups, with a carrier frequency of as high as 1 in 5 for the variants. Now, mind you, not all of these have pathogenic variants. Most of them are variants of unknown significance, but still this is a very high carrier frequency. And the disease itself, as you can see, is probably more than 1 in 1,000. But FMF has been reported in other countries, in Europe and Japan as well. And in the International Euro Fever Registry, we have had over more than 200 FMF patients with pure European ancestry, without an Eastern Mediterranean ancestry. So it can occur in Europe as well, but in Europe, it's a rare disease. In the United States, it's a rare disease because it's less than 5 in 10,000, and that is the description of rare disease. Whereas in the Eastern Mediterranean, it is not a rare disease. It's actually one of our probably most common inherited disease, and it's 1 in 1,000 in all this region: Armenia, Cyprus, actually south of Greece as well, and Israel and north of Africa. I guess this audience knows the features of FMF, and this is an old cartoon showing that almost all of them have fever, they have serositis. This serositis can be in the form of arthritis. Erysipelas-like erythema is confined to the patients with severe variants, usually M694Bs. And we've also known for a long time now that these patients tended to have more inflammatory and sometimes more rheumatic diseases more commonly than we would expect in the normal population. We have shown these, our colleagues in Israel have shown this. And it's interesting that although, for example, some of these inflammatory diseases, inflammatory bowel disease, henoch-Schönlein purpura, pericarditis is more common, the autoimmune diseases are less. So when we looked at the comorbidities in a large cohort of FMF patients, more than 2,000, we saw that lupus was less than expected in the general population. That is probably because of their high CRP that gets rid of the apoptotic blebs. It's not just the attacks that these patients suffer from. These patients also suffer from the clinic sequelae of chronic inflammation, in the form of anemia, in the form of growth retardation. We have shown that they have decreased bone density if you don't treat them. Of course, they have a terrible quality of life if you don't treat them. And of course, the most important one is secondary amyloidosis. So we have to treat these patients adequately so that they don't develop this very severe morbidity with potential mortality. And we're lucky that in the recent years, we haven't been seeing any secondary amyloidosis in children anymore. Well, we do see it still in adults. When you see a patient, there are a number of ways you can use for a number of criteria you can use for diagnosis / classification. Our adult colleagues from Israel had suggested a criteria, diagnostic criteria. We suggested a more simple one in children, but I think from now on we should use this new classification criteria of Eurofever, where we suggest that you can classify a child as FMF if the child has a confirmatory MEF genotype, meaning 2 pathogenic mutations, and at least one of these. Duration of episodes less than 3 days, arthritis, chest pain, abdominal pain. We also suggest that if you don't have a confirmatory MEF genotype, and this is quite common, a patient with just one severe mutation, or a patient with, variants of unknown significance, then to classify that child as FMF and start colchicine treatment, you need 2 of these. These criteria have a quite high sensitivity and specificity. So I think these should be the criteria that we should use, especially in multi-ethnic populations. Now, what are the red flags in a patient with periodic fevers that should lead you to think about FMF? Well, attacks lasting than 3 days, because, in most of the other autoinflammatory diseases, they last longer. High CRP, being able to exclude common infections of childhood. So having a normal ultrasound, normal urinalysis, normal complete blood count, etc. And of course, if there's an Eastern Mediterranean ancestry, that is of course, again, a red flag. The differential diagnosis includes a lot of things. You have to think about infections. You have to think about the other monogenic periodic fever diseases. You have to think about PFAPA, which is a great problem in children younger than 5 years of age, because we have a problem in distinguishing PFAPA and FMF in that age group. Inflammatory bowel disease, differential diagnosis, and maybe an onset of malignancy as well. And actually, polyarthritis nodosa and DADA2 are also in our differential diagnosis in a patient who comes with febrile myalgia, very high CRPs and fevers and so on. So we faced some difficulties in diagnosing FMF. And the main difficulty is because of these variants of unknown significance. Okay, we have pathogenic variants in MEF that we are sure are very pathogenic, like the M694V, but then we have some of these other variants where we are not so sure they can cause a phenotype on their own, and we're not sure how they contribute if there's a pathogenic mutation on the other side. They usually do. So this is an autosomal recessive disease, but we all have patients who express the disease with one mutation only. So although they are, theoretically carriers, they sometimes express the phenotype, and you have to give them colchicine for some time. That's another problem. We're not sure if the carriers are predisposed to certain inflammatory diseases, and that's another problem. Some years ago, we tried to come up with what mutations are important in FMF. And of course, we suggested that exon 10 mutations were critical, but there were some others that you needed to look at in the other exons. Recently, a group of clinicians and geneticists came together, and this has just been out, I think, this paper, where we have again suggested which mutations to screen for classical FMF. You should do exon 10, but there are also variants of unknown significance, which you have to screen for because they are pathogenic if there's a pathogenic variant on the other allele. And we have acknowledged that there are sometimes dominant FMF-like transmissions as well, especially with these variants, especially with the M64 deletion. And we also acknowledged that there was one mutation that was associated with a dominant transmission and a completely different picture called PONT. So periodic disease with neutrophilic dermatosis, described by Seth Masters a couple of years ago. So now the workup of FMF genetics is much more complex, but to cut a long story short, exon 10 means, okay, pathogenic mutations, but you also have to look for these variants of unknown significance. A number of years ago, we suggested a workup for patients. If you have 2 mutations, you're fine, you can start colchicine. But if you have only one pathogenic mutation and a variant of unknown significance, or 2 variants of unknown significance, you really have to be sure that you don't have one of the other autoinflammatory diseases. You have to make sure of the diagnosis before you start colchicine. And if you have only one variant of unknown significance, think about other things. It's probably not FMF. So I get questions like this from all over the world with internet. For example, this patient with a Jewish and Italian ancestry, 2 days attacks of fever. The patient has M694V and E148Q. Is this FMF? Well, you have to make sure whether he was tested for the other rare mutations, and maybe he has a variant of unknown significance, which would, make the phenotype of FMF possible. You have to check whether these 2 variants are in the same allele or in different alleles. So if they are in cis position, then this patient is more likely to be a carrier. So you need to check the mother for this, not the father, please. And you have to check whether the patient has any other accompanying features suggesting the other autoinflammatory diseases. Management and treatment. The most important thing in the management of FMF patients is to be sure of the compliance with colchicine. Make sure that they're taking their colchicine. And apart from that, we came together as a group of clinicians taking care of FMF patients all over the world. And we tried to develop some recommendations for the management of FMF, especially for physicians who do not see so many of these patients. The methodology started with a systematic review, then we had consensus meetings, and we came up with 18 recommendations. We started with more than 1,100 papers, and in the end, there were 153 full text articles to employ. I won't go over all of these 18, but just touch upon some of them. So one of the recommendations was that treatment of colchicine, and this is the starting treatment, mind you, it should be 0.5 milligrams per day for children younger than 5 years of age, and you increase it accordingly. Now, this is a starting dose, and you have to adjust the dose according to the response, the ISSAID criteria, and you also have to adjust it maybe according to the mutations and according to the compliance of the patient. But these are the starting doses that we have suggested, and it's in the paper. We have also suggested that dosing can be single or divided doses. This depends on tolerance and compliance. In children, I really like to give divided doses because in single doses, we have more GI side effects. And since the mothers give the drug when they are young children, you can have divided doses. But for a grown-up, for an adult, it might be a problem to take divided doses, and then you might favor compliance over side effects and ask the patient to take a single dose instead of a divided dose. So the turning point for FMF was colchicine. We use colchicine since 1972, and it has indeed changed the fate of these patients, and that's why we suggest colchicine for these patients. But I will stop here, and I will leave the microphone to Özge to share a patient with you, and then I will continue try to answer Özge's questions. Özge.
Okay, thank you, Dr. Özen, for the introduction. Good afternoon, good evening to all. Today, I'm going to present you a case from our center, Hacettepe University. So she's a 15-year-old Turkish girl with a diagnosis of colchicine-resistant FMF. She was presented at the age of 3 first with recurrent febrile episodes. On those episodes, she had fever above 38 centigrade degree, she had abdominal pain, and sometimes arthralgia was accompanying these attacks. The frequency was like every 1 month or every 2 months, and duration was 3 to 4 days. Her inflammatory markers were elevated during these attacks, and she was well other than those periods. After several visits to emergency department, and after several, she saw her general practitioner several times. She was referred to our center at the age of 5 with a concern of diagnosis of FMF. Review of systems was negative. Review of rheumatological systems was negative as well. But her family mentioned about an erythematous rash on the dorsum of her foot. So after her physical examination, it turned out that it was like an erysipelas-like erythema. On past medical history, there was nothing remarkable. Immunizations were up to date. And on family history, there was no consanguinity, no family history of rheumatological disease. But her uncle died because of end-stage kidney disease and with possible diagnosis of amyloidosis. So on physical examination, her temperature was high, and also she had that erythropoietic rash on her foot. Her blood work revealed a slightly high white blood cell count, and her blood chemistry and urine were normal. Her inflammatory markers were elevated with the high ECR and CRP levels, and serum amyloid A was high as well. So when we checked the problem list, she had recurrent fever and abdominal pain attacks. She had this erythropoietic-like rash, and her inflammatory markers were high during these episodes and near normal or normal other than attack periods. So an FMF DNA was requested, and it revealed an homozygous mutation on the exon 10 of Mediterranean fever gene. So she got the diagnosis of FMF, and she was started colchicine. After the start of colchicine, her attack frequency didn't change much. Her CRP was high even between attacks. So first, we tried to make some adjustments about the colchicine dosage for her weight and for her age. But as you can see here, it didn't work very well. So the attack frequency was same, CRP was high. And during those years, she was on an appropriate dosage of colchicine, and she had a full compliance of colchicine. So we decided to add anakinra. And after the start of anakinra, her attack frequency and duration decreased. Like it was 2 or less than 2 attacks per year. Duration was 1 day or 2 days, and her inflammatory markers decreased as well. But after a while, she started to have some complaints about the daily injection of anakinra. She had some kind of local reactions on injection sites like redness or tenderness. So we switched anakinra to canakinumab. She's now 15 years old and is doing very well with canakinumab every 8 weeks. And she's also on daily colchicine. No, she has no attacks and complaints, and her inflammatory markers are in normal range. So here we have some questions for our experts. First, when do we say colchicine resistance? Second, should we continue colchicine after starting IL-1 blockers? How often do we assess the CRP levels, and when do we stop biological treatments? Okay, thank you for paying attention to our case. I'm going to stop sharing.
Right.
Yeah.
And I will take over the sharing. Okay. Thank you, Özge, for that patient. So as to Özge's first question, well, for the persistent of attacks and inflammation, we do suggest an increase in dose in these ISSAID recommendations that I have just presented to you. And we also suggest that compliant patients not responding to the maximum tolerated dose should be accepted as resistant, and alternative treatments are indicated in these patients. And of course, these alternative treatments are one of these anti-IL-1 drugs. And we now have the cluster study showing that anti-IL-1 is indeed effective in resistant colchicine. So what is colchicine resistance was the first question of Özge, because we have to have a definition so that we can decide on whether we're going to start this patient on biologic treatment, which is a serious decision. So to answer this question, again, a group of experts came together, and we've adapted, again, the systematic literature research and consensus meetings to come forward with a definition for colchicine resistance. This is submitted work, and in this work, we suggest that to call a patient colchicine resistant, the patient should be receiving the maximum tolerated dose of colchicine and should still have ongoing disease activity, reflected either by recurrent clinical attacks of greater than 1 per month. So we do introduce a number here, or persistently elevated CRP, or if you can do SAA levels in between attacks. So this is important as well, in between attacks, in the absence of any other plausible explanation. So we suggest this should be used as the criteria to start anti-IL-1 treatment, biologic treatment in a patient with FMF. And we hope that all health authorities in all countries would cover this expense for these children. The second question Özge had was, should we continue colchicine after starting an IL-1 blocker? And the answer is yes. Because colchicine is a primary treatment for preventing acute attacks. It does reduce attack frequency, and we accept that it also is an important factor in preventing renal amyloidosis. Now, actually, this depends on a paper of years ago, a very old paper, but it was a very nice paper with a longitudinal follow-up, and it provides us with high evidence that indeed colchicine is needed. And you can't get any ethic committee to agree to stop colchicine for these patients. And that's why even when we start anti-IL-1 treatment, we suggest to continue colchicine at an acceptable dose that the patient can tolerate on the background. So colchicine continues. A third question was, how often should we monitor these patients? Well, these ISSAID recommendations for the management of FMF, we have suggested as the 9th recommendation that response for the colchicine or biologics, whatever you're giving, toxicity of the drugs you are giving, and compliance with the drugs you are giving should be monitored every 6 months. And we also stated that colchicine should not be discontinued during conception, pregnancy, or lactation. So yes, you should monitor these patients every 6 months with a complete blood count, with a liver function test, CK test for toxicity. You should check the compliance. You should check the response by the patient quality of life and IDI score preferred. And we also suggest that liver enzymes should be monitored regularly at these visits. If liver enzymes are elevated greater than 2-fold upper limit of normal, colchicine should be reduced and the cause should be investigated. And the 11th recommendation of these ISSAID recommendations was that if the patient had decreased renal function, the risk of intoxication is very high. Therefore, signs of colchicine intoxication as well as CPK should be monitored and colchicine dose should be reduced accordingly. So the fourth question Özge asked was, when can we stop biologic treatment? Now, the jury is out. We have no evidence-based data on this. What we do in our clinical practice is that we try stopping the biologic treatment. Of course, we keep them on colchicine after a year or two. And sometimes we give on-demand colchicine treatment and anti-IL-1 treatment. For example, for girls who have attacks during their menstrual periods. But the jury is out. We don't know how long we need to continue. There are patients that we cannot stop the anti-IL-1 treatment, and we refer them to the adult clinic with anti-IL-1 treatment on top of colchicine. So time will show if we can have a biomarker to tell us when it is possible to stop the anti-IL-1 treatment and just keep the patients on the cheap colchicine drug only. So I'll stop there to take your questions, and I'd like to thank my colleagues and patients. And I will finish up with this historic patient. So this was a meeting in NIH in 1998, just a year after the definition of the gene. You can see Dan Kastner here. You can see Isabel Tuitu. Hure, for the people who know her, Eldad Ben Shetrit, Avilivne. You've seen a lot of papers of him, and this is a very young me there. So, okay, I'll stop there and take your questions. Thank you very much for listening.
Very good. Excellent. Thank you very much indeed. Excellent presentation. And to say that also to Oscar was very nice and very well presented. I have to say that I'm very, very, very happy because the quality of the presentation, of course, but also the fact that we break the wall of 210, now are 212 participant, and I have to say to all of you that we are more than 400 registrations. So it's a great success. I'm very, very happy. So please spread the news that the webinar of ISSAID are so nice. And thank for the capability of the speaker. So we have a number of questions, unfortunately in two different sites. One on there is a box of question and answer, and the other is a chat. So I will try to go from one to another, and if needed, and also if the people want to enter, maybe we can also have some discussion live, let's say, with the speakers. So I'll try. I start with the box. There is a colleague, I think is a colleague from China, Cesar, that Yan Peng Sun, that say how to explain some patients suspected of FMF while carrying only one pathogenic variant in the context of an autosomic recessive trait. We can start the colchicine, but can we make the diagnosis of FMF? Please, Cesar.
Okay, so this is a question we have been looking for answers for 12 years now, and we don't have a definite answer. To cut a long story short, first of all, for diagnosis, I think I will refer to the Eurofever criteria, where we suggest that if you have only one mutation, but if you have, two of those criteria, you can call that patient FMF and you can start colchicine, since you think that patient has the phenotype. Now, we think these patients with one mutation only display the phenotype because they have some extra variants in other inflammatory genes. For example, they have a wrong polymorphism in the, say, IL-1 gene that makes them produce more IL-1. They have a variant in the gene for, say, TNF that makes them more susceptible to inflammation, or they have a very strong environmental factor, such as lots of infection and very high stress that leads them to display the phenotype, although they shouldn't. And so we think it's the second allele in this case acts as a multifactorial disease allele. So although you have one mutation, and this is a monogenic disease, if you have very strong wrong polymorphisms on the other allele, and if you have some wrong environmental factors, you might display the disease, even as a carrier. Now, having said that, we do try stopping colchicine in heterozygotes if they are free of attacks for 4 or 5 years. If we are sure that they don't have any other mutation, and we've done a exome screening and everything.
Okay. Thank you. Cesar, we have plenty of questions, so we have to
Cut it short. Okay.
But we have we have also plenty of time because we have 20 minutes, so we have plenty of time, so we can.
But this was a very tough question.
Absolutely, very, very, very important and tough questions. Thank you very much. So Alberto Contreras asked, even when you don't have access to genetic test, it is valid to start treatment with colchicine when FMF is suspected?
Well, if you have a patient with an Eastern Mediterranean ancestry, I think it's okay. But if you have a patient with pure European ancestry, I think I would go for a mutation analysis first, because in the European population, mevalonate kinase deficiency is as frequent as FMF. And, it can be hard to differentiate them on clinical grounds only. So if it's pure European, I would go for a mutation analysis.
Cesar, may I ask you? I think it's difficult to more difficult to make the diagnosis of other recurrent fever in Turkey or in Israel rather than Europe. What is your suspicion? Not to judge a patient like FMF, but another periodic fever.
You're right. We might be missing some patients. What we do, Marco, is we always do a MEF mutation analysis when we have a patient with periodic fever. We start with a MEF mutation analysis, whatever the patient has. And if the patient has 2 mutations, that's fine. If the patient has 1 mutation only, we then, think about the other autoinflammatory diseases. We, investigate the patient for other features. But if the patient is lacking the other features, we do start colchicine. If the patient is resistant to colchicine, or if the patient has some features suggestive of the other autoinflammatory diseases, such as rash, such as diarrhea, such as macrophage activation syndrome, such as myalgia, then we go for a panel analysis for the other periodic fever diseases.
Okay, thank you. Janine Jagger, I don't know if she wants to comment, because also to enter live if you want, Janine, because she said you recommend having confirmed diagnosis before starting colchicine. But there are also mutation negative FMF cases in which positive response to colchicine confirm an FMF diagnosis. This is a contradiction. So I don't know if Janine was to clarify or to discuss with Cesar, but Cesar, you want to comment?
Yeah, okay, so like 20 years ago, we would agree with this. Now today, if you are sure, because the genetic techniques have improved so much, if you have done an full screening for the MEF gene and you don't see any mutations, in no variants of unknown significance, nothing in the MEF gene, I would not call that patient FMF. But we do know that colchicine is effective in some of these periodic fever diseases because of its mode of action. It affects the activation of neutrophils. It activates inhibits the Rho-GTPase pathway. So it is effective sometimes in patients with undifferentiated autoinflammatory disease. But if the patient does not have any variant in the MEF gene, I would not call that patient FMF anymore. I would still try colchicine in Turkey. I do admit that, because colchicine is so cheap and it's so safe, and we have so much experience with it. But if the patient responds to colchicine, I will say this is an undifferentiated autoinflammatory syndrome responding to colchicine. Excellent. I don't know the disease, but it's responding to.
We call them SIRF.
SIRF. Yeah. Syndromes of undifferentiated.
Yeah. Janine, do you want to enter and comment? Also show you.
Yes. Can you hear me?
Yes. Hi, Janine.
Yes.
Hi. Yeah, this is really important from the patient's perspective. Patients really don't care whether you diagnose them as FMF or not. They care whether they can get effective treatment.
Right.
And colchicine is such a good drug that just doing a colchicine trial is really helpful to patients, setting a low bar for doing a colchicine trial in patients. The other thing is that, making these discriminations on genetic tests, when you have, the geneticist making those distinctions, that's one thing. When you talk about patients, it's a completely different thing, because patients' access to their own genetic data is so minimal. Patients don't have enough genetic information for that, those decisions to be made.
Sure. It is very clear. Thank you, Janine. Thank you very much.
I agree, Janine. I mean, I very much take your point. And actually, we do that in Turkey because we have, you know, so many years of experience with colchicine, and we know that it's safe and cheap. But I mean, if I was a European doctor dealing with European patients, I mean, I might have had second thoughts. Hard to answer, but I hear you. You're right.
Okay, we have to move on. Thank you very much. So Monica Immaculata Tortosa Fito would like to ask you for some things about the neurological manifestation of FMF. Are you aware of some neurological manifestation?
Yeah, there are case reports, especially from Israel, from adults, that report these patients might have headache or even aseptic meningitis. We haven't seen any. I mean, I don't know, maybe because we start colchicine timely, or whether, I'm not sure whether these patients, the historical patients with meningitis in FMF, I do suspect they might have had some other autoinflammatory disease that we did not know at that time. Neurological features are not classical components of FMF, I can say that, but they do have an increased incidence of multiple sclerosis, I can say that.
Okay. Oh, there is my friend Leonardo Oliveira Mendonca from Brazil. We are everywhere in the world, and he say, do you evaluate SIBO, they cancel small intestine bacterial overgrowth in patients with diarrhea with colchicine? What do you think about considering a trial with probiotics? Leonardo, if you want to say, but in the meanwhile, Cesar can answer.
Yeah, hi, I love Brazilian colleagues. Hi. So, yeah, well, this is a tough question. One of my colleagues did think about starting a probiotic trial, but we didn't do it. I mean, it could have an effect. What we do when we have diarrhea with colchicine is that we suggest to stop lactose. So we suggest them to take lactose-free milk products, and we suggest them to divide the dose. It usually works, but you know, it might be worth trying probiotics in these patients. I'm not against it. I mean, it wouldn't do any harm.
Are you happy with that, Leonardo? Do you want to comment?
Yeah, no, thank you very much, Professor. It's because, thank you, Cesar, again. But it's quite common for us here in Brazil, like in our center, that our FMF patients, when they start having diarrhea, we also have this positive test for small intestine bacterial overgrowth. And somehow, I don't know if it works or if it's some other effect, that probiotics usually help them to tolerate colchicine for longer than they were expecting.
It might work. I would believe in it. I mean, you should do a study.
We
did check the microbiota in patients with severe disease versus mild disease, and it wasn't different. But this was a small cohort. So it would be worth giving probiotics, and I think it's a good idea.
Excellent. Thank you. So Natasha Toplak from Ljubljana. Hi, Natasha. She asked, if you want, she won't, of course, enter in the discussion. Hello, what would be the highest dose for colchicine in a 5-year-old child? And then she also asked how you consider the K695R mutation is pathogenic or not. But the dose of colchicine is rather interesting. How high you can go?
Yeah, well, we don't have agreement on that. I know my colleagues in Israel are more liberal in increasing the dose. For a 5-year-old, I would never go over 1.5 milligrams.
1.5?
1.5. If I need to, I will start anti-L1. So I don't like going very high with colchicine, but I know that our colleagues in Israel are more liberal about the dose. With that variant, I think it's a variant of unknown significance.
Okay. Natasha, any comment?
Thank you. Hello, everybody. Thank you, Cesar, for
Hi,
answering
Natasha.
my questions.
Take care.
Hello. Hello. I mean, this, I don't know how to call it, variant or mutation. This is the most common variant that we see in our part of the world, in Central Europe, Eastern Europe, at least in the studies that we have done. This was the most common change, but it was connected with some strange clinical pictures with macrophage activation syndrome or some malignancy. There was one patient actually later diagnosed with, first with myelodysplastic syndrome and later with leukemia, and was having periodic fever, and this change in FMF, this was in my early start. So I'm having problem with this change. So I'm giving you hard times to you and to Ivona every time that I have the chance, because it really bothers me. And I don't know what to make of it.
Yeah, thank you.
That's interesting. It might be worth checking the IL-1 levels.
Yes. Yeah. Maybe also some, yes, the function of pyrin in this special variant. Thank you, Natasha. Abdul Adam Al-Sharashid, I'm sure that I had some mistake. I'm really sorry, but he asked how to explain patient with typical attacks of FMF and heterozygous to A108Q. Just to come back to this, it's just are they reserved? They respond to colchicine or not?
Yes.
What do you?
Like you said, I think A148Q on its own is just a variant of unknown significance on its own. If you don't have any other mutations, I would carefully check for other autoinflammatory diseases. Otherwise, I would like to call it an undifferentiated autoinflammatory disease responding to colchicine.
Do you want to comment something? Maybe another experience or some other suggestion? Abdullah Radam?
No, thank you very much.
Thank you very much for your, let's say, comment. Anna Rundkrantz, can you please elaborate a bit more on when on-demand treatment with IL-1 may be beneficial for patients? Anna,
yes, well, what we did was, I mean, we've had teenager girls who had terrible attacks during their menstrual cycles, or we had patients having terrible attacks with a fibromyalgia, or we had patients having attacks during a very stressful time of, losing a parent or, exams and so on. And in these patients, we saw that we could get away with very short periods of anakinra, just when they needed it. And then we stopped it. There were few patients, but I think we'll continue this trend, especially in adolescent girls who have attacks during their menstrual cycles, 1 or 2 or 3 days of anakinra and then stop.
Okay. Hannah, do you want to comment? Are you okay?
Oh, I'm okay. Thank you very much.
Excellent. Thank you very much. It's very nice to also to listen to the people. I think there's a way to stay together. And I think it's a very important.
I forgot to open my Zoom light. Anyway, sorry.
So we have 5 minutes. If you don't mind, says that we can go a little bit further. I don't know if we have to pay some more money to MCI. I don't know. And
no, that's fine.
It's for free, even with the Swiss euro. But however, of course, everybody is let's say open to go, but we will stay for some minutes more because there are plenty of questions, and it's nice to chat a little bit all together. So Hala Lofty, can long-term therapy with colchicine induce any form of gluten sensitivity in children?
Not that I'm aware of.
No, me too.
No,
do you have some experience of that, Hala?
Good afternoon, everybody. Yes, sometimes when patients are on colchicine therapy for a long time, starting from early age, some patients have severe diarrhea and when we performed investigations, including biopsy, this biopsy revealed a form of gluten sensitivity. And that's
Not
why I was
lactose
wondering.
intolerant. Uh-huh.
No.
Okay.
Actually, as colleagues elaborated before, in Egypt, usually when we prescribe colchicine, we usually use probiotics in addition, and this is يعني, a common trend. But the gluten sensitivity I'm observing in few patients lately, and I don't know whether this is a coincidence or it's related to the colchicine. Thank you very much.
Okay.
Yeah, that's interesting. We're not ever aware of that in the Turkish patients, but you know, it might be possible.
Okay, very interesting. Another good friend, Anna Sendiva from Prague, she asking that they experience some shortage of colchicine in summer months. Any problem in other countries? Something to replace colchicine? Wow.
No.
It would be a disaster.
No. Buy it from Turkey. Turkish lira is so cheap now.
Anna?
Oh, yeah. Hi, everybody. You know, thank you. Actually, it was very difficult. You can imagine patients calling, chasing pharmacies, and it lasted for several weeks, but then it came back. So it's very difficult. It's not replaceable. I could not find it.
I know, you're right.
You have to go abroad because we didn't have any shortage.
Yeah.
I know it's difficult, but
Next time I will call you.
Yes.
Yeah, for sure.
It's very cheap in Turkey.
Yeah.
Okay, just we have 3 minutes for some other question. And then Cesar, I'm sorry, but if you go to the Zoom webinar chat, you will pass your evening to reply to, because there are, I don't know how many questions. There were something like 30 questions. So
wow. Okay, Özge, you can answer them.
It's always good. We can. Okay, as usual. Because it's dinner time, more or less, in Turkey. Is it?
Yes, it's
okay.
8:30.
Okay, Wala Showman asked the presence of one or more MEF gene mutation in patients with other inflammatory condition. This is interesting, as IBD or systemic onset juvenile idiopathic arthritis, without expressing a classical FMF attacks. Does this justify using colchicine in this patient?
So just one mutation, just one variant in the MEF
One
gene.
or more FMF gene mutation in patient with other inflammatory condition.
With other inflammatory. Well, that's a tough question. I mean, I would very carefully question the patient with any symptoms, any phenotype of FMF. If you don't have any phenotype of FMF, I don't think you need to give colchicine. But to tell you the truth, for example, in PFAPA patients, we do give colchicine even if they have one mutation. And sometimes we do give colchicine for ankylosing spondylitis patients, even if they have one mutation. So, you know, sometimes we think it's good to help you control the inflammation, but really the carriers we know are more predisposed to develop certain inflammatory conditions and certain rheumatic diseases. We have known this and written about this for years now. And it is probably because they have a heightened innate immune system response. So it's not a surprise that they're having more JIA, they're having more inflammatory bowel disease. So I guess you have to judge it on a case-to-case basis.
Very good. Very important question. Thank you very much, Vara. Go on. Okay, yes, this is I can confirm that it's possible and absolutely mandatory to register the patient in Eurofever registries. So this I can talk also on behalf of states, of course. Anastasia Antaniadou, though, I'm sorry. When would you decide to start biologic as on continuous basis instead of giving a anakinra on demand? When the patient starts experiencing an episode?
No, just as I mentioned, if the patient meets the criteria for colchicine resistance, I think you can start the patient on permanent anti-IL-1 treatment, and then you will have to judge when you can stop it, if you can stop it. But to start the patient on biologics, I think you should use the definition that the consensus group has come up with. So having more than one attack per month and having high acute phase reactance in between the attacks.
Very good. There is a CL that I don't know the name, of course, but you're asking for a ferritin as a possible marker of the inflammation versus CRP. What do you say?
I have never looked at ferritin because it comes back late, so and it's more expensive. I've never checked ferritin.
Okay. But while again, I think it's interesting, is there an association between FMF and pancreatitis? Any experience on that?
Nope.
Anybody has?
Nope. Well, we've seen more than 3,000 patients not had pancreatitis. Okay. I'm not sure about the adults. The adults might have it.
Well, I don't know. Do you want to comment a little bit on that? Do you have some experience of this kind of problem? If you want. No.
Yes. I just have a single patient who is genetically positive. He has two different pathogenic mutations of in FMF gene. He has a strong family history of FMF. However, he doesn't express the classic features of FMF at all. And he presented with
patient. An adult
no, he's 5 years old child.
5 years old. Wow.
Yeah. Wow. He presented with dull aching abdominal pain for about 2 months. And while I was not convinced that he has FMF, I started to investigate the abdominal pain. I do amylase and lipase, and he revealed to have chronic pancreatitis. Okay. So far, I couldn't reach the reason for pancreatitis, and he doesn't express the FMF disease, although he has 2 mutations.
Yeah, but he's 5 years old, so he might express the phenotype later on. It's interesting. You can write it up as a case report. I mean, this is the first case of pancreatitis I'm hearing in FMF.
Yeah.
Thank you.
We just the last few minutes because the time is running. I like to ask to call Raffaele Manna because he want to give his experience from Rome, my good friend from Rome. On this group, our group demonstrated that SIBO eradication can improve colchicine treatment. This is
what application?
I don't know if Raffaele want to do.
Yes, rifaximin treatment and lactic enzyme. Rifaximin, eradication of small intestinal bowel overgrowth by rifaximin. Rifaximin, yes, can improve colchicine tolerance when there is small intestinal bowel overgrowth, bacterial overgrowth. Okay.
Right. So you're writing that up, aren't you, Raphael? You should.
Yes.
Okay.
So we can finish. I think with there is a question I think interesting and also is also because it's didactic from my friend Sulaiman Al Mayyouf. Hi Sulaiman, how are you? From Saudi Arabia. It's fantastic this tour of the world. I love it. Sulaiman, do you want to give the question by yourself?
Well, good evening, everybody. But
hi,
you know, hi. We have a patient who has phenotype fit with the MVK or heads, but the West showed, let us say, 1 copy of MEF gene. So in this case, would you consider him as heads and ignore the MEF gene? Mind you, the response to colchicine, and we escalate with short courses of prednisone, then we add or we introduce interleukin-1, but still the response is not the best. When I said IL-1, anakinra, we don't consider canakinumab yet.
Okay, so there have been a number of reports in the literature with these digenic mutations. So this is a digenic mutation, right? 1 mutation in the MVKD and 1 mutation in FMF.
No, the MVK homozygous.
MVKD is homozygous, and the
Yes.
patient also has an FMF mutation.
Yeah, but the MF gene is only one copy.
Yes, but wow, okay. So of course the patient is going to have a lot of inflammation. You have to give him anti-L1, you have to give him colchicine, hopefully they're going to work. Maybe you're going to give steroids on demand. It's just, I think it's an add-on effect for these mutations. So I think you're facing severe inflammation in this patient.
Okay.
We
Thank you very
also
much.
have a response from Ivona for Natasha. And Ivona says that functional studies do not support pathogenicity of K695R. And it's certainly not a single variant. It is relatively common variant in Caucasians. So maybe your patients had other mutations in other genes. Natasha.
We cannot refrain to ask Ivona to say something.
Yeah, Ivona, hi.
Hello
Thank you for the comment.
Hello to everyone, and thank you for this really wonderful presentation. And just, it's nice to see your face on the screen too. So.
Yes, I've missed you. Hi.
And I would like to congratulate to Marco and whoever initiated these seminars, because they're just a really great way, you know, to see you all and to communicate with our colleagues throughout the world.
Yes.
Excellent. Fantastic. Thank you very much, Ivona. I think that I'm sorry because the questions are so interesting, so many, but I'm afraid that we have to stop. I think that Özge will have a lot of work during the dinner time. And
tomorrow, not now.
So two things. So was, I think, very good success. I'm very happy. I have to also remember very well that we have to give our thanks to Novartis that supported this initiative, that is supporting this initiative. I can remember by heart when the next webinar will be, if the ladies from MCI can help me. But however, you will receive for sure the advertisement that now is going very well. So I would like just to thank you, all of you, for the participation. It was very nice to hear the voice from many friends from all over the world. I'm very, very moved. And I would like really to thank Özge and Professor Ozen for the fantastic presentation, very clear, a lot of questions. We enjoy a lot. Thank you, Cesar.
Thank you. Thank you, everyone.